This is Dr. Tariq Haddad. He is a cardiologist who specializes in general cardiology and nuclear cardiology. He has a special interest in conducting clinical research and is the director of the hugely successful research center at Virginia Heart, one of the leading research centers, not just in this country, but in the world. He earned his medical degree from Cornell University Medical College and continued his training with his internship and residency at the University of Virginia Hospital. He completed after that multiple fellowships at Johns Hopkins University and the National Institutes of Health. He has also pursued additional training in cardiac MRI and CT imaging. Dr. Haddad is board certified in general cardiology and internal medicine. He participates in the physician panel for Inova's preventive cardiology program. And early prevention is a key to avoiding heart disease. Our preventive cardiology program helps you manage your heart health before symptoms arise. And Dr. Haddad is going to tell us a lot about that this evening. This program is for those at risk for heart disease, but not yet diagnosed with serious cardiovascular disease. Dr. Haddad is on the medical staff at Inova Alexandria, Inova Fairfax, Inova Fair Oaks, and Inova Loudoun hospitals, and he sees outpatients at the Virginia Heart Fairfax office in Falls Church. Dr. Haddad, we're looking forward to your presentation. I'm going to go off camera now. If you want to bring your slides up, the program is yours, and I will see you at the end.
Sounds good. Hi, everybody. My name is Dr. Haddad. It's very nice to speak to all of you today. Preventive cardiology is one of my passions. Any patient who's seen me knows there's nothing that makes me happier than just trying to prevent the disease rather than waiting until afterwards when things have already happened. So I just wanted to speak a little bit today about really the numbers, what I call the numbers that matter. In other words, you all get thrown a lot of numbers at you with labs and things. How do you put it all together as a patient? How do you sort of, put it all together and understand a little bit more about how we use those numbers as cardiologists to prevent heart disease? And that's kind of what I wanted to focus on today. So the question is, why does it matter? So heart disease, as many of you know, is the #1 cause for death for men and women. And the problem is most of the things that cause heart disease are pretty silent. In other words, you feel fine until you're not fine. A lot of people, the first time they realize they have heart disease is a big heart attack. And what people don't realize when they have heart attacks is they didn't have heart disease starting just at that point when they developed a heart attack. They, on average, have heart disease that's developed slowly over 10, 15, 20 years before they got to that point of the heart attack. They just many times didn't know they had it. And we're going to talk tonight about ways that we can work on these risk factors. How can we kind of prevent it during that 20-year window so that hopefully none of you actually get a heart attack? And that's kind of what we're focused on today. So what are we going to focus on? So one is, how do we decipher your cholesterol panel, your lipid panel? You get a lot of numbers thrown at you. Your doctor may say, this is this number, this is that number. What does that mean? What should that mean to you? What is lipoprotein A, an area that I'm extremely passionate about. I do a lot of research on it, and it's probably one of the most important areas in cardiology right now. And how does that number matter? What is the value of a calcium score? A lot of times your doctor may mention to you, you have a calcium score. What does that mean? What is a calcium score? What are the blood pressure numbers and the sugar numbers that matter? And then how do we put that all together with your lifestyle to hopefully do what we think is success, which is to prevent a heart attack in the first place? So that's what we're going to work on today. So starting before we go through the numbers, I think it's important to get on the same page about what cholesterol is. So it's a waxy kind of fat-like substance. You can see the picture on the right part of the screen. That's what plaque looks like. So when I often talk to patients, I'll say, yeah, we're trying to prevent plaque. Well, this is what plaque looks like. This is a cut of an inside of an artery. And you can see that yellow stuff is plaque, and it slowly builds up over years and years, before you develop a heart attack. So this is what I mean when I say that your heart disease doesn't start the minute you have a heart attack. It starts years before, because this plaque grows over 20 years, slowly forms. A lot of things make it worse. And then eventually, if you don't treat it enough, a clot forms right on top of that plaque, and that's when the heart attack happens. So how do we how do we try to prevent that cholesterol from causing problems? And what does that mean for your numbers? So many of you will recognize when you look at your cholesterol panels, there's going to be a total cholesterol number, often abbreviated as TC, right? There's the LDL, which is the bad cholesterol, the total, and then you have the HDL, which is the good cholesterol, and then your triglycerides. Now, what do these all mean? So the total cholesterol is just the sum of all the cholesterol types. It's both good and bad. So it's certainly, you don't want it to be really high, but it also includes some of the good stuff. So you don't necessarily care as much about your total as you do about the LDL. The LDL really is one of the main ones out of these four that you're going to focus on because it correlates the most with the formation of plaque. You have the good cholesterol, which again, the better that is, the higher that is, generally the lower your risk of heart disease, but it doesn't substitute for having a good LDL or bad cholesterol. And then finally, your triglycerides. Triglycerides are the fat in the blood, and that's the most correlated to what you're eating. So generally, people whose diets are not really very optimized, they're going to have higher triglycerides. If they're overweight, they're going to have more triglycerides. This is much more associated with kind of your metabolic health, as we call it. In other words, like how good is your waist size and how good is your diet and all that kind of stuff. The triglycerides tell us a lot more about that. So why does LDL matter so much? Why does this number something that we care about? Well, because it really significantly increases your risk for heart disease. And we see this, the slides, the right side of the slide, it kind of looks at a study that shows what happens to your risk of heart disease, of heart attacks and heart problems with your LDL. And you can see the curves, basically the higher your level of LDL, the higher your risk of heart attack. It's a very, very clear relationship. And not only is the higher your cholesterol LDL, the higher your risk of heart attack, but the opposite also means something. In other words, the more you lower your LDL, the lower your risk of heart disease. And that there's a very, very clear relationship of about every 40 point drop in your LDL that we can achieve through diet and through statins and cholesterol medicines. The lower your risk of heart disease by around 20 or 25% is how much you lower it by. That's a very, very consistent relationship. Every 39 to 40 point drop, you're going to get about a 20-25% drop in your risk of heart attack and stroke. So it's pretty significant. You know, I always tell patients, it's not hard for me to lower your bad cholesterol, your LDL by around 80 points. Dropping your LDL by 80 points by this curve means you're dropping your risk of heart attack almost in half over your lifetime. That's pretty impressive. What other numbers are things you may see on your lab? So the non-HDL and the ApoB. So sometimes your doctors may look at that. The non-HDL also tells us about some of the bad cholesterol particles. And oftentimes, if you're not sure how bad the LDL is, your doctor may look at that as well as kind of a tiebreaker. The ApoB also, ApoB and LDL also are some of the bad cholesterols. And I always tell patients ApoB is kind of the more refined version of LDL. You don't necessarily need to use it all the time, but that one is a lot more of the bad cholesterol particles than the LDL. So again, if you're not sure, ApoB can tell you a little bit more about just how high risk your numbers are. And it's, and remember that, what your liver makes often is what determines a lot of these numbers, not always just what you eat, right? That your diet has an effect, but some of it is also genetics and what your liver is doing. This is a nice, this is a busy slide, but I think it's an important one. This is kind of a summary of almost every cholesterol study ever done with statins. And what you see here is pretty impressive. So this is over 150,000 patients worth of studies in all these studies. And what you see is in all these studies, all the patients started with a certain LDL and they ended with a certain LDL if they were on statins. And what you see is a very consistent relationship. On the y-axis is the event rate. And what that means is the rate of heart attack and heart disease. And what you see is very clear. The lower the LDL got in each of these studies, the lower your risk of heart attack and stroke. It's a very consistent relationship. And you can see it goes lower and lower the lower your LDL is. Some of the studies started at LDLs of 200 and they had event rates that were much higher. Once the studies started to get LDLs down to the 50s and 60s, the risk of heart disease lowered even more, got down to 5% or so. So the lower your LDL, the lower your risk of events, and there's no magic number where that stops. It continues to go the lower your LDL is. The ApoB I mentioned is another number you may see, and as I said, That's another very helpful marker if we're not sure just how low to get your LDL. The 9-HDL we talked about is your total. That's your total cholesterol, and we subtract out your good numbers, your HDL. And again, those are all numbers that are much better to look at things as a tiebreaker, especially when your triglyceride numbers are high. So what can affect your LDL? So there's a lot of things, right? So your family history or your genetics can affect your LDL. Many patients have really high LDLs and they're skinny, and that can be just genetics. Your age affects it, typically your LDL will go up as you get older. Your race and your ethnicity does affect things as well. Certain patients, Filipinos, Japanese descent, Vietnamese descent, Asian Indian can all have higher LDLs just through their genetics and their hereditary their background. Your gender, so women are typically more protected until they hit menopause. Then their LDLs typically go up. And this is typically when I see patients who are women who tell me, I don't know what's going on. My LDL just went up, and they hit 55 and they're beating themselves up. And I have to explain to them, this is nothing to do with what you're doing to yourself. This is just happens with menopause. Your LDL goes up. Unhealthy eating habits can often affect things too. So, when you're eating too much saturated fat-rich foods, that can also, not necessarily overall fat, but saturated fat has a big effect. Not being physically active can affect your cholesterol. Smoking can affect your cholesterol in a bad way. Drinking a lot of alcohol affects your cholesterol. Being overweight. So all these things can affect your LDL. And what are some things from a food standpoint? So, you can have more olive oil, avocados, walnuts. These are all things that improve your HDL. You can have things that are higher in fiber like oatmeal, apples, oranges, salmon, tofu. These are all things that can lower your triglycerides and your LDL. Things that raise your LDL are things that are high in saturated fat. So egg yolks, fatty meats, shellfish, full fat dairy, processed snacks. And then triglycerides can go up with excessive drinking of alcohols, too many simple carbohydrates or starches, and then a lot of animal products or sugars. So the simple things, eating a heart healthy diet, getting regular exercise, losing weight, not smoking, staying on top of your risk factors and medications can all affect this. How often do I need to check my LDLs? And a big question a lot of my patients ask. And generally, if you're under 40, you should still get it checked every couple of years, especially more frequently if you have some hereditary problem with high cholesterol. Once you hit 40, because heart disease risk goes way up, you probably should get it checked more often. So if you have heart disease every 6 to 12 months, less often if you don't have heart disease, but at the very least, at the age of 40, even if you're healthy, you should get it checked once a year. Anytime we make a change to your medications, we generally will check it about 2 or 3 months after we make a medication change, because that's how long it takes to get the full effect of the medicine and see if it got down to where we need to be. So what do we do when lifestyle and diet aren't enough? You're doing everything lifestyle-wise, but your cholesterol is too high. Then in that case, typically we'll start with statin medications. And generally statins have the most data. I showed you that slide with how dramatically they reduce heart attack risk. Usually they'll cut your risk of heart attack in half. They work in the liver on an enzyme that actually causes you to make cholesterol. So that works really well. It targets that. It also lowers your triglycerides. It can boost your good cholesterol. And most importantly, other than your numbers, they prevent heart attacks. Like I said, on average, they'll cut your heart attack risk and stroke risk in half. And they shrink plaque. They keep the plaque from rupturing and causing a heart attack. So a lot of good things that these medicines do for this. Who are the people who should take statins? That's a complicated question to answer, but generally they fall into 4 groups. If you have heart disease or plaque buildup anywhere in your body, whether it's your heart or somewhere else, those people should be on statins because they have the highest risk of developing heart attack. If your LDL, even if you're otherwise healthy, but your LDL is above 190, that's a category of people that usually have a lot of hereditary problems causing it. And because it's often hereditary, but if it's above 190, those patients are recommended to be on a statin too, because there's no way with lifestyle alone you can get an LDL down from 190 to where it needs to be. If you're in that intermediate age range, 40 to 75, and you're diabetic, that's another category of people who should be on statins. And then finally, if your risk of heart disease, and we'll talk a little bit more about how to estimate that, you can do that on your own actually. If your heart attack risk is high enough based on your risk factors, that you would benefit from being on one, that's another category of people. So how do we estimate risk in people who are otherwise healthy? Well, we use a couple things. This is called the ASCVD risk score, and it's by the American Heart Association. And you just plug in all the risk factors we know, your blood pressure, your cholesterol numbers, your age, your gender, and we'll usually plug that in, and that'll tell us a lot about what your risk in your lifetime for heart disease is and what is your risk in the next 10 years. The most recent version of this is called the Prevent Calculator, and you can actually access this on the American Heart Association website. But it's very nice. It utilizes, hard to see this, but again, looks at all your numbers. You plug them in. Your doctor plugs them in. What your diabetic status is, whether you're smoking or not, whether you're on medicine or not. A bunch of numbers that we usually use, and that will spit out a number that'll tell us, yeah, your risk of heart attack or stroke is in the neighborhood of 10% over the next 10 years. Well, that's if you get to a number that high, usually your doctor will look at it and say, this is a high enough number that you're going to really benefit from lowering that risk with the medication. Or they'll say your number's pretty low. I think lifestyle by itself should be enough. You may not need a medicine. What other factors other than the risk score can increase my risk? These are other things your doctor may look at. So is your family history pretty bad? Do you have a brother or father had a heart attack at 45 or 50? Is your LDL really high, like 160 or more? Do you have chronic kidney disease? Kidney disease increases the risk of heart disease. Do you have a chronic inflammatory condition? So if you have rheumatoid arthritis or HIV or Crohn's disease or lupus, we know inflammation. I always tell my patients, inflammation, think of it as like Velcro, that it makes your arteries stickier for cholesterol. So if you have an inflammatory problem, you're more likely to develop plaque, even if your numbers look good. And those are people who we usually treat a lot more aggressively. If you're female and you have premature menopause before the age of 40, or pregnancy-associated problems like preeclampsia, which is blood pressure problems during your pregnancy, those are things that increase the risk of heart disease over your whole lifetime, even after you've delivered or had a baby. If you're South Asian descent, Pakistani or Indian descent or African American descent, these are populations that have a particularly higher risk of heart disease that aren't accounted for by those estimates. If your C-reactive protein level, that's a number, a lab test that tells us about inflammation in your body. If that's high, that may also tell your doctor that's going to increase your risk more. And you have a high lipoprotein A level. That's another number that's, again, we'll talk about, that tells us more about your risk. Or if you have a high calcium score, and again, we're going to go through all this. So what numbers, you may be asking at this point, okay, Dr. Haddad's talked about the LDL and all this stuff. What exactly are the numbers that we look for? Well, because it does get confusing. A lot of patients come to me and say, yeah, but the LabCorp lab said that the LDL was normal because it's under 100, right? Because they'll have like a value that says normal or abnormal. You can't look at that because it's not the one size fits all. It really depends on your risk. This is the most recent guidelines that came out from the National Lipid Association. And this is a busy slide, but I'm just going to walk you through it. And basically what it shows is the number of the magic LDL number that is recommended for you really is not one number. It depends on what your risk is. The higher your risk, the more we got to lower your cholesterol more so that we keep the plaque from growing. So the highest risk people at the bottom part of the slide are those who've had heart attacks before, who've had bypass surgery, who've had a stent placed, right? Who've had a prior stroke. These are patients who are the highest risk for having more problems, and their LDLs now are recommended to be 55 or less. If you are kind of in the intermediate range, so you're diabetic, but you haven't been diabetic for very long, or you don't have heart disease, but your risk is a little bit higher for heart disease. Those are people your doctor will say 70 is probably okay in you. If you have a calcium score that shows really early plaque, but it's not terrible, okay? Those would be somebody who, yeah, LDL 70 is probably okay, 70 or less. And then the people who don't have anything, right? So no risk, that's high, nothing like that. We may say 100 is probably okay in those patients. So again, this is not for you to decipher, but I'm just giving you an idea how we use those numbers. It really depends on your overall risk. So again, to summarize all that, the bottom line, how low does your doctor want your LDL? We want your LDL to be as low. The higher your risk, the lower your LDL should be. The highest risk people should have an LDL under 55 because those are people who, if you lower it to that level, they have the lowest risk of heart disease. And those numbers, that's how we use those numbers. So shifting a little bit more to what about people who can't take statins, right? So first of all, if you have a side effect of statins, remember they're not all the same. They're metabolized differently. So if you have a side effect of one, I often will say, let's just try a different one. They're metabolized very differently. And most patients, if they don't tolerate one, they'll tolerate another. And we don't want to give up on them too easily because they have the best data for lowering heart attack risk and shrinking that plaque. If you don't tolerate them, though, we have a lot of options. We can use other medicines like Zetia, like Repatha or Praluent, which is what's called PCSK9 inhibitors, like another medicine called bempedoic acid. Nexletol is the other name for it, which is really good for people who don't tolerate statins at all. It's been looked at in that population. And there's other ones like inclisiran. If you can't take them, again, we still have a lot of options. When do we use them? When statins aren't enough, right? If we can't get your LDL low enough to that goal despite the statins, or if they stay high, or if you have a genetic condition like what we call familial hypercholesterolemia, where it's so high that there's no way that one medicine is going to get it down enough. This is a slide that shows you all the different recipe of options that we have now to lower your cholesterol, depending on how high your number is. Bottom line is, with a statin, with a good dose, we can get you down, your LDL down about 50%. If that's not enough, we have a lot of other options. If we add other things, Zetia, things like that, we can get it down to 68%, 70%. If we use 3 medicines, we can get it down 86%. So there's a lot of options. So you shouldn't be discouraged if your cholesterol is really high. Your cardiologist has a lot of options to potentially get it down. So shifting over to calcium score numbers. So what does that mean? So, you hear a lot about this. I have patients ask me, is that the calcium in my diet? Is that what I'm eating? No, it's not. What the calcium score is, and this picture in the middle shows you actually a real calcium score. The idea is that where plaque is on the right, you can see this on the right-hand side of the screen, where plaque builds up in your arteries, your plaque has several things. It has cholesterol, which we cannot image. We can't take pictures of cholesterol because it doesn't light up. It also has inflammatory cells, so, all the inflammation. And then the third thing that's in that plaque is calcium. It's kind of like the glue that puts all that plaque together. It's not the dietary calcium. It's not the milk you're drinking or the calcium supplements. It's just calcium that builds up from aging and from your body. It's unrelated to diet. But the reason we call it a calcium score is the CAT scans, like the calcium score, can light up calcium. That's what lights up. So where you see calcium is where you have plaque. And so the more calcium dots, you can see that white stuff in the middle of the screen, the more white dots you have, the higher your calcium and the more plaque you have. And you can see on the bottom part of that slide, it'll spit out a number. So when you get a calcium score, it'll say your calcium score is 0, or your calcium score is kind of in the mild range, 1 to 99, or it's 100 to 300, or it's above 300. And the more calcium you have, the higher it is, the higher your risk. Okay, and it's an extremely helpful test. And I'm going to show you a little bit about why it's so powerful in terms of predicting your risk of heart disease. So again, this is what a calcium score look like depending on the person. The one on the top picture shows a calcium score 0. You can see there's nothing lighting up there. There's no white plaque or anything. And that's fantastic. I'm smiling with my patient when I see that, because that means their risk of heart attack in the next 10 years is under 1%. You can have a calcium score that's just a little bit. You can see the one on the right-hand side of the screen. It's like a little ditzel there, the calcium score 29. That is a little bit of plaque, but it's not terrible, right? So your risk is a little bit high, but not horrible. Then the calcium score 250 on the bottom, you can see a lot more white ditzels there, and that's kind of in the medium range. And then really the one on the bottom right is the highest risk. That's 1200. You can see with that white stuff everywhere in the middle. And that's somebody who has a lot of plaque, okay? And that's somebody who we got to talk about throwing the kitchen sink of their cholesterol so we can keep that plaque from growing. This is a really nice slide to show you why this calcium score is so important. So this graph shows in a lot of patients, about 25,000 patients, they did a study, and they looked at what does it predict in terms of, what does that calcium score predict in terms of your survival? And it's pretty impressive. So if you have a calcium score of 0 to 10, it's predicted that you have a 99% risk of living the next 10 years. 99%. You're essentially immortal if that calcium score is 0 for the next 10 years. If your calcium score is above 1,000, your risk of living in the next 10 years is about 82%. So a lot less, right? So about, your risk of having a major problem is much higher at above 1,000. If you're somewhere in the middle, you can see that risk of survival goes down a little bit more as the higher your calcium score is. So the numbers don't matter as much as just understanding that it's very predictive of what your risk is. So now shifting over from the calcium score numbers to lipoprotein A, one of my favorite areas because it's a passion of mine, and it affects over 1 billion people in this world. So it's like LDL, but the difference is it's way more predictive. Lipoprotein A is hereditary. It's what you were born with. And it's if your LPA is high, it can quadruple or higher even more your risk of heart attack compared to somebody with a normal LPA. It's passed on through families. If you have it, about a 50-50 shot that your daughter or your son has it. It's not affected by lifestyle. And a lot of people have a high LPA, they just don't know it, about 1 in 5 adults. That's much more common in people of African descent and African Americans and South Asians, but other people can also get it. It increases inflammation, it increases plaque buildup, and it increases blood clotting. So the big three that you need for a heart attack, it does all three. So somebody with a high LPA, they're going to develop plaque much faster. These are the people who oftentimes will get stents or heart attacks in their 30s or 40s. And so we really got to, people who have a high LPA, we have to treat them very aggressively to keep them from developing heart disease. Who's more likely to have it? If you have a really bad family history, because again, it's hereditary. So usually if the patients, if I have a patient who tells me, yeah, my brother had a heart attack at 45, every one of my siblings had a heart attack in their 40s, my dad had a bypass surgery at 50, my grandfather died of a heart attack at 58. These are the people who have high LPA, right? So because it's hereditary, it's passed on. All those people that I just mentioned had a high LPA. Those of African American descent, South Asians, but of course you can still have it. I have plenty of Caucasian patients who have a high LPA. Patients who have heart disease at a very young age. If you develop, I had a patient I saw the other day who had, was in her early 40s, and all of his arteries are blocked up with artery blockages, and I checked an LPA and it was 400. So these are the people who develop LPA, who have LPA. They just develop heart disease at a much younger age. People keep having heart attacks despite having a good LDL. Those are people that often have a high LPA, because if you can't explain why they keep having heart attacks, even though their risk factors are good, it may be something hereditary. So what do you do if you have a high LPA? So, and again, getting back to our theme of our talk, the numbers, I should mention that a high LPA is neighborhood of 75 nanomoles per liter. That's the number, the magic number above 75. If it's high, you got to have a discussion with me or another cardiologist about, you got to control every one of your risk factors even more than you would otherwise, knowing that your risk of heart disease over your lifetime is triple or quadruple as high as somebody else. So it's even more important in those patients. I have really tough conversations with them. Look, you got to control every risk factor. Your blood pressure's got to be excellent. Your LDL has to be perfect. Your weight needs to be at your ideal body weight. You got to control everything you can control over, and be a lot better about your lifestyle than you would otherwise, knowing that LPA is increasing your risk. You got to make sure your family members get tested. I always tell patients who have a high LPA, remember, your son has a 50-50 shot of getting it. And it's important for them to know early so they can be more attentive to their lifestyle. You want to keep your bad cholesterol, the LDL, as low as possible if you have a high LPA, because if you have a high LPA and you have a high LDL, your risk is even higher. So it's really important to keep that LDL really low if your LPA is high. And then there's multiple medicines that I often offer to patients through clinical trials that look like they're lowering lipoprotein A by 80 to 95%. Very impressive stuff. And we're looking right now in studies to see if lowering that LPA with these medicines can lower heart attack risk. But that's certainly an option for a lot of patients, and you can certainly reach out to me later on if you have a high LPA and you're interested in that. These are some resources that I offer to read about LPA as a patient. I offer these to my patients all the time to look after visits. Cardiosmart.org, and then the other one is the American Heart Association, the website heart.org. They both have outstanding patient-centered material on LPA, and I highly recommend reading about it a little bit. What about other things like prediabetes and blood pressure numbers? What are those numbers that matter? What are those magic numbers? So, diabetes doesn't just start magically, right? You slowly develop early diabetes, borderline diabetes, and then you get to it, just like plaque. So it's very important to treat this before you get to the magic number for becoming diabetic is a hemoglobin A1C or A1C of 6.5. But when you get being pre-diabetic, you got to take that seriously. You can't wait till you get to 6.5. So when you're in that 5.7 to 6.4 number, which correlates to a glucose number in the 100 to 130 range or 125 range, you got to start really tightening up that lifestyle before, because you can prevent the diabetes. If you get to that point and you're exercising religiously 30 minutes a day, you may prevent diabetes. You may keep it from happening. If you get your body mass index down to a normal level, if you get your waist size down to 34, these are all things that can prevent you from developing full-blown diabetes if you're in that pre-diabetic range. What about blood pressure number? What magic number is important there? Well, this is actually fairly brand new from this year, is that the data clearly shows now, and the guidelines have changed in this regard, that that magic number is you don't want it above 130 for the first number on average or above 80 for the second number. It used to be, we said 140/90, and the data more and more is showing that people are at higher risk for heart attack and stroke at lower numbers than 140/90. So it's not okay, just ignore it because you're at above 130/80, but less than 140/90. You still got to take that seriously because your risk is not as low as it would be if you were 120/80. So really 130/80 is that magic number for blood pressure. They're both very important contributors. And then lifestyle changes, most importantly, can reverse both. It's not just about the medicines. You know, you can lower your blood pressure 10 points by just exercising 30 minutes a day. You know, what about the blood pressure numbers at home? A lot of patients ask me about that. Do they matter? And the answer is yes, they do matter. And the reason is because your average blood pressure at home, when it's taken the right way, it's been shown to really, really help predict the control of your blood pressure much more accurately than just the occasional numbers in your primary care doctor's office or your heart doctor's office. You want to make sure you're checking it the right way, and you don't necessarily care about the individual numbers, but the average blood pressure over you know, period of time is what I usually tell my patients. How do you check it most effectively? So this is very important to do it the right way. This is actually from the guidelines. This you got to make sure that you're just like this gentleman who's sitting in this chair, that arm has to be at your heart level. You should probably use an arm cuff. You got to make sure that you avoid smoking or caffeine or a lot of exercise within 30 minutes before checking it. You want to put your cuff on a bare arm, not with a lot of, you know, with a sweater on or something. You got to relax, and this is very important. I always tell patients, you got to be relaxed. You got to be sitting in a chair for 5 minutes, okay, before you check it. That's the most accurate measurement. Don't be talking on the phone or having an argument with your kid while you're checking it. That's not going to be helpful. Take 2 readings about 1 minute apart. And then just record them. Don't worry about the individual numbers. Just get an average trend for a couple weeks, checking it maybe twice a week, and then bring those numbers to your primary care doctor or your heart doctor so they can look at that trend. But the individual numbers, remember, don't matter. If you had a bad night's sleep, your number may be higher. We care more about what the trend is, okay? And then finally, I'm going to end with, you know, what are the lifestyle changes that help with all these numbers? So just getting back to the basics, Mediterranean diet, very important. Eating fish and eating vegetables and having lean proteins and you know, just eat a Mediterranean diet, olive oil, tree nuts. The American Heart Association website, that heart.org, has an excellent section on that if you want to read more about it. Getting 150 minutes a week of exercise, very important. Maintaining a heart healthy weight, and then managing your stress and getting enough sleep. These are all important things. And finally, I'm going to end with putting it all together. Start with just making sure you get your cholesterol checked. Make sure you get your blood pressure and your sugar checked at least once a year. Get a calcium score if your doctor feels it's going to help refine that risk and know what that 10-year risk of heart disease is. Check your LPA at least once in your life, and then make sure you treat your lifestyle aggressively with lifestyle medications. And of course, always, you know, happy to chat with you more about it. You know, if you ever want to see me in the office, I'm more than happy. This is one of my passions, and I love talking to patients about this. So again, know your cholesterol numbers, know what they mean, check your LPA, and check a calcium score if your doctor feels it's going to be helpful for your risk. Lifestyle makes a huge difference. And then early detection means more prevention, longer life, and less plaque and less heart attack risk. This is the website for the Inova Preventive Cardiology Program, which includes the 4 cardiologists you see below. I'm one of them. This is the Preventive Cardiology Program that focuses more on prevention. And this is some more information for how to reach any of the doctors on that list, including myself. And I'll be happy to take any questions.
Wow, that was great, Dr. Haddad, and thank you for taking your slides down. That was awesome, and we're going to get to our Q&A section now, and a lot of questions are coming in. I'm going to try to group it by topic. Take a breath, catch your breath for a second, and let's start with let's start with coronary calcium scores. It's a topic a lot of people are talking about. One of the questions brought up the fact that a couple of things aren't covered by insurance companies. One of them is a coronary calcium score, so maybe give people an idea of what it costs. And then the other thing, interestingly, and the question was, this person's insurance company also would not pay for an LP little a, and said it's not a valid or valuable test. And so what are we doing about these things? And because we know it's an obstacle to having patients get these things done.
Yes, these are excellent questions. So the calcium score, believe it or not, sometimes they will, often they will get covered because they're in the guidelines now. There are, whoever the person was who asked, they're absolutely correct that a lot of times they won't. But the first step is just make sure that it really isn't covered, because I've had patients tell me that, yes, if for a certain diagnosis, that it was able to get covered. If it can't be covered, generally, it's still, if your doctor feels it's helpful to refine your risk, it is absolutely worth it. And I would not hesitate. You should shop around. There's several places to get a calcium score, and sometimes the amount, if you're paying out of pocket, it differs. But generally, we're talking about a cost of anywhere between $150 to maybe $400, depending on the place, in that neighborhood. But generally, that's what we're talking about with a calcium score. As far as the lipoprotein A, it will get covered a lot by insurance if you pick the right diagnosis. And that's not on you as patients, that's on our doctors. So if you're getting pushback, just maybe contact your doctor's office and just make sure they're putting the right diagnosis. Because I have talked to LabCorp and Quest, and they have told me that there's a list of diagnoses that insurances will often cover, because the guidelines support now, those guidelines that I mentioned to you all, they say everybody should get an LPA once in their lifetime. You don't need to keep getting it checked, but every patient should get one in their lifetime. So the insurances should cover it, and just make sure that it's not just the wrong diagnosis or something.
Yeah, I think the answer there is push back on your doc, because you can get that approved. In talking about coronary calcium scores, let's talk about a couple of other things. When you start a statin, what happens to your coronary calcium score?
Oh, that's a really good question. So,
Yeah.
so we'll start before we get to that. I have to explain a little bit about that. So, what happens is, remember, what the statins work by a couple of ways, and I mentioned that in my presentation a little bit. But they lower cholesterol, but they also stabilize plaque. And the way they stabilize plaque and keep you from having heart attacks is, remember the first or second slide I showed you guys of the plaque building up and then rupturing. What the statin does, and this is the way I explain it to patients. Think of like a wall in your house. You have drywall. What the statin does is it's actually adding more layers of drywall on top of that plaque, and essentially making it so it's much less likely to rupture and cause a heart attack. Now that drywall, that extra layer of support that keeps the plaque from rupturing into a heart attack, includes calcium. And so you can often see the calcium score going up after a statin is started. That's not dangerous calcium. That's actually from the drywall layers being added that are going to keep your plaque from actually rupturing and causing a heart attack. So it's actually good calcium in that case.
And the other question would be, how often should you repeat a coronary calcium score? And I'll give you two scenarios, okay? I'm 42 years old and I got a coronary calcium score of 0, and you're happy. Or I'm 55 years old and I got a coronary calcium score of 450. When should both of those people repeat their coronary calcium score, if ever?
Excellent. So yeah, so the first scenario, so somebody who we're using it the way we should, which is to refine their risk. Your doctor thinks you're in that medium risk range that we talked about, and he really wants to know, are you at low risk or are you at higher risk? So it should be checked in that scenario. And in that case, if it gets done and it's 0 and you're in your 40s, generally it won't change much in over the course of about 5 years. So unless something dramatic has changed, you probably can get a rechecked in about 5 years. In terms of somebody in their 50s, if your calcium score is in the 400s, you should be on cholesterol medicines. You absolutely should be on a statin. And in that case, it's not going to help you to keep checking it. It's not going to magically go down. It will be the same or higher. And even if it is higher, it may be higher because for the drywall, right? Because you're having more drywall being built. And so that's not a bad thing. So I would not worry about checking the calcium score again once it's high.
Thank you. That's something that I think a lot of patients have trouble understanding. It doesn't give you a sense of progression of disease. Let's talk about LP little a's, however. So how often should you check an LP little a during your lifetime?
Good question. It generally stabilizes once you hit your early 20s. So, if you have kids who, let's say a patient has like a high LP, I have this all the time, and then their kids are around 18. I'll tell them, just wait a second. It's not going to change what we do right now, but maybe check it when they're 20, 21. Once it's your 2021, it will not change over your lifetime unless a couple scenarios happen. If you develop major kidney disease can raise your LPA, or if you're female and you hit menopause, because your LPA will go up a little bit with menopause, not a huge amount, but it will go up a little bit. So the general answer to the question is once in your lifetime, because it's hereditary. But if you hit one of those scenarios where your doctor doesn't know your risk perfectly, you develop major kidney problems, or you're female and you've hit menopause, not unreasonable to check it after menopause. That'll give you a better estimate of what your risk is.
Thank you, Dr. Haddad. Let's move on to statins. And we always get a couple of questions that I'll admit it bothers me because there's still this false narrative out there that statins are bad for you, right? And so some of the questions tonight were, well, why are you pushing statins? There's all this negative commentary out there. Or why do physicians claim that statin medications have no benefit and actually harm the body because they lower cholesterol, which is needed? Can you, like, once and for all, clear the air about statins? What percentage of people, number one, actually can't take them, develop side effects, right? And what is the data about statins? I mean,
Right.
they're great.
These are great questions. So, and I get these all the time. So the people in the community who've been asking these questions, you're not alone. A lot of people come to me with these questions because it's out there, right? So I'm going to address a couple of the big ones. So first of all, what is the risk of side effects? We're talking about in studies of over maybe 200,000 patients at this point. We're talking about a 5% risk of some muscle aches. Okay, muscle aches. The muscle ache risk is not permanent. If you develop muscle aches, then it's very easy to treat. Oftentimes they go away. There's certain things we can do, and sometimes we can even switch the statin and it goes away. I get questions all the time. It causes it can cause liver problems. That's actually very, very a big urban myth because the risk of any significant liver problems we're talking is under 1%, to the point that actually the FDA has removed the requirement for checking liver function tests in patients with statins, because they specifically stated in the review of the data that the risk it's the same as not being on anything at all, that it's not even worth checking. As far as other side effects, the sugar stuff, somebody mentions sugars. It can slightly raise your blood sugar, but generally what the studies show is number one, if you're on a statin, you need one, you're cutting your heart attack risk again in half. So if you're raising your sugar a little bit, in return for that, I'll take that any day. Number one. Number two, it never, unlike what a lot of patients think when they read stuff about this, it doesn't make you diabetic. If your sugar goes up, on average, somebody who was gonna become diabetic anyway, because they're right at that border of becoming diabetic, it makes you diabetic 3 months earlier in your lifetime than you would anyway. So it's not taking somebody who's not diabetic and they're magically becoming diabetic. You just cross that threshold 3 months earlier. But I'll trade that any day for cutting my risk of heart attack in half. And that's what the data shows, is the average statin will cut your heart attack risk in half. And that's to answer the question of the person who asked, why did people push it? I don't push anything. What I focus on is what's best for my patients. And I'm not going to withhold something that I know can cut the risk of heart attack in half, and does so safely.
So real quickly, some people get a little bit confused. What has better data in terms of risk reduction? And I think people also get confused. If you can lower your cholesterol other ways, does that have the same risk reduction of lowering your cholesterol with a statin, right? And I was going to ask another question, but can your cholesterol be too low? Is that dangerous? And if you had to choose between a ezetimibe and a statin, which one has better data associated with it?
Right. So good question. All good questions. So the lifestyle. So lifestyle is very important. And as I said multiple times in my talk, and I'm going to say it again, everything starts with lifestyle: exercise, eating right. For the purposes of an LDL, though, if we're comparing statins to lifestyle, we should never compare because it's not one or the other. It's always whatever you need to lower your risk. But the bottom line is, with lifestyle, you can lower your cholesterol if you are absolutely perfect with your lifestyle and doing all the right things. Okay, you're statistically going to lower your LDL about 20% at most, 15, maybe 20%. Okay. So if you go back to those guidelines that we talked about, you often, if you're at the highest risk category, your LDL should be below 55. If you're going to try to lower, if your goal is to lower your heart attack risk the most, there's no way if your LDL is starting at 150, which is the average patient, that you're going to get, 20% with lifestyle of 150 is not getting you anywhere to close to sub 55. So it's really where you're starting at. And that's why it's not a substitute, because statins will lower your LDL in half. Lifestyle will lower it about 15 and 20% at best. Now, the question about too low, this is a very common misperception. I talk about this to patients all the time. Remember, your brain makes its own cholesterol, number one. Okay, so you don't, and if you look back at studies of people, back from the hunter-gatherer era, and there have been studies such as this. There's a lot of data to show that the average LDLs way back when were actually in the 30s. Okay, and this is before the the industrialization and all the stuff and the McDonald's and everything we do here. But the bottom line is, you don't need a lot of cholesterol to function, and most of it is already created by your brain. It's not through, and on average, what the studies show is there is no too low of an LDL. That curve that I showed you guys, there are studies of the injectable medicines like the Repatha where the average LDL got down to the 30s, and many of those patients got down to LDLs that were under 10. Okay, and those patients had lower heart attack risk than those patients who had LDLs in the 60s or higher. So, and they had no increase in side effects, no worsening problems, no cognitive problems, no increased liver problems, nothing. And this is in studies of 15,000 patients. So the lower your cholesterol, the lower your risk of heart disease. That's the bottom line.
Okay. I've got a last question on statins. At what age should you start a statin? And is someone too old to be on a statin? So I'll give you two examples. A 30-year-old who has an LDL of 160.
Yeah.
Maybe a family history. I'll throw that in. And then an 80-year-old who has a high coronary calcium score, and you do something and you find they have some mild coronary disease.
These are all both excellent questions. So I'll start with the first example. There's one of the things that most of the studies show as well, it's not just your cholesterol number, but your lifetime exposure to cholesterol that matters. This is really important. In other words, if you think about it, the longer your body's exposed to high cholesterol, the more plaque's going to build up. It makes sense, right? The higher, the more, so the person who develops an LDL in the 160s to 190s at the age of 20 is going to have a much higher risk over their lifetime of heart disease than somebody who develops that same LDL, but they develop it in their 50s or 60s. So it's the lifetime level. So if you develop a really high number at a much younger age, I'm going to be more aggressive with you because you probably have a good 70 years of being exposed to that high cholesterol. So if you are in your 30s and your LDL is 160 or higher, I'm going to be really hitting that lifestyle hard with you, understanding that's going to be a big impact on you. And if your risk ends up being higher, if you have an early calcium score that's too high, or you have a lot of risk factors or whatever it is, I'm gonna probably be more aggressive about lowering it down to lower levels. The person who's older, those studies that I showed you guys about lowering your risk of heart disease, that lower risk of heart attack and stroke doesn't get lowered immediately. It slowly gets lowered over time for the most part. So if somebody is 80 or 85, there's no magic number. I have very robust 80-year-olds who I expect to live to 100, and I have some 80-year-olds who are in nursing homes and have a really terrible quality of life. So it's not a magic number for age, but what is your life expectancy? If I expect what most preventive cardiologists will tell you is if your life expectancy, if we think you're pretty healthy and you're robust and you can live, we think that nobody can predict, but we think that you have a good 10 years of life left, you probably could benefit from low cholesterol reduction. If your life expectancy is probably under 5 years, very unlikely the lowering your cholesterol aggressively is going to make a big difference, because that cholesterol reduction, again, takes time to lower plaque and lower heart attack risk.
Great, thank you. And that was very clear. Let's go to blood pressure for a second. A question I get a lot. What do you think of wrist blood pressure cuffs?
Yeah, they're not recommended as much. They're not as accurate, and the guidelines that actually just came out actually in the last couple months really recommend more of the arm cuffs. It's probably better to stick with the arm cuffs. They're more accurate and they're a better representation of what what your actual blood pressure is. If you have one and you have to use it or whatever, it's okay. But if you're going to do that, my recommendation would be that calibrate it. In other words, next time you see your primary care doctor or your cardiologist, just bring it in and then calibrate it, have it checked at the same time as a nurse or a medical assistant is checking your blood pressure with his or her blood pressure and her stethoscope. If it's accurate, then it's probably okay to use. But generally, I prefer the arm cuffs. They're more accurate.
Yeah, I agree. A couple of questions were interesting here, Dr. Haddad. One was, gosh, my lipids were always wonderful. My doctor kept praising me, even told me to go eat a steak once in a while. Or the person who said, I had a coronary calcium score done. It was like 12. I was really happy. And then both of those patients within a year had major cardiac events. And what I liken this to is, if you never smoke, you can still get lung cancer. But this isn't an all or nothing. You can have a normal cholesterol and still have coronary disease, and you
Yeah.
can have coronary disease without calcification. Is that correct?
That's correct. Yeah, it's all about, as with anything, like, you can predict, but you can't know 100%, right? So if you come to see me and your calcium score is 0, right? I can tell you prediction based on hundreds and thousands of patients is that your risk of a heart attack is under 1% in the next 10 years. Okay. Can I say that that number is 0? No. Could you be one of the 1 in 100 who has a heart attack in the next 10 years if you have a calcium score of 0? Yes. But you can feel pretty good that that risk is very low. I just can't predict that it's 0, right? If your calcium score is 1,000, I can predict that your risk of a heart attack is very high. Over your lifetime, it's going to be over 50%, 1 in 2 chance or more. Can I say for sure you're going to get one? No, because if you do the right thing, if you do all these things, and even if you don't, some things come up are for chance, but all you can do is play the odds. You can go to Vegas and play the odds the best way you can. And the best way to play the odds is to lower those risk factors as much as possible.
Okay, Dr. Haddad is not recommending that any of you go to Vegas. March Madness is not here yet. I'm going to give you a chance to talk about something that you love and is very near and dear to your heart. And it actually came up in our last Ask the Expert webinar in talking about high LP little a. And I think you may have mentioned that right now we don't have any medications that can address elevated LP little a's. However, there are several in the pipeline. And you are the head of clinical research at Virginia Heart. And I know you have several protocols, studies that are looking at some of these new medications. Questions that came up during our last talk was, if I'm interested in getting involved in a clinical trial, what can I do?
Right, great question. So
I have a high LP little a. What can I
yeah,
do?
so there's probably around so internationally right now there's 1, 2, 3, 4, 5. There's 5 trials going on right now of various medicines that can bring lipoprotein A level down to normal. I actually, as this is one of my areas of specialty and something I'm actually one of the national leaders in a lot of these trials. In other words, one of the people who coordinates them. So any of the trials that are going off ILPA, absolutely, you can try to contact our office at Virginia Heart, at our research office, so you can look at the website for Virginia Heart's research department and reach us. And we can happy to look and see if you qualify for one of these. Just to go through a little bit about what Dr. Levy was talking about, in terms of, so none of the approved medicines right now lower LPA, but how all of these medicines that are in clinical development are doing, which is pretty cool, is ApoA is LPA is created in your liver, and it has 2 building blocks, ApoA and ApoB. And to make a long story short, when your LPA is high because of genetics, it's because your body's making too much LPA through your liver through ApoA. So what these medicines do, which is really clever, is it reduces your liver's overproduction of ApoA, the building block. If it's like you're turning the faucet down. If you turn the faucet down on the liver going gangbusters making ApoA, you cut down your LPA by like 90%, which is really impressive. And all these medicines, there's about 3 of them, 4 of them actually in development right now. They all do this safely. And what the studies are looking at is quite simple. They're all looking to see, we know they lower LPA, we know they do it safely. Does doing that in patients with high LPA lower heart attack risk? And that's what they're looking at. We should have the first study that shows this coming out probably. I'm involved in this actually. I'll be involved in publishing it as well probably, but around March or April, you can look out for that first one. That'll be the first one that'll probably show whether it reduces heart attack risk, but there's 3 or 4 other ones. So even if that one isn't as good, we'll see if the other ones do it.
We're almost out of time, Dr. Haddad. I'm going to ask you 1 or 2 real quick questions because this came up and I think there's stuff in the press and it can be confusing. We're back to calcium again. And there's always confusion about calcium supplements for bone strength or calcium in your diet or the calcium that we see in arterial walls. But there is some stuff out there about calcium supplements. Can that increase the amount of calcification of arteries in your body versus dietary calcium, which doesn't?
Right. So it's not, yeah, exactly. That's a good point. So yes, there is some data that sometimes excessive amounts of calcium supplements can potentially, increase the risk. Having said that, yes, dietary calcium, no issues there. While we're on that topic of supplements and all that, because I saw a ton of questions about this, just generally speaking, same thing goes for all the other stuff. Natural sources of fish are very, very good for lowering heart attack risk. Fish oil does not lower your risk of heart attack, and multiple studies have shown that. The same thing with somebody else was asking about mineral oil. Generally, you just got to get the good fats and good cholesterols from your diet, not from supplements. And that's been looked at in studies. Garlic, for example, people look at garlic. Garlic actually raises your LDL. People talk about red yeast rice, which is a natural version of statins. Really has almost no effect on your LDL. Just get the stuff through your diet. Eat more fish, have more olive oil, have more avocados. That's the way to improve your cholesterol through that. Supplements really do not lower heart attack risk.
Thank you so much, Dr. Haddad. We are unfortunately out of time, and I apologize.